Hi, I'm Veronica Carullo, and I'm joining you again for part 2 of ascending and descending control of pain. In this module, we will discuss acute to chronic pain and management strategies. Once again, I have no financial relationships or conflicts of interest. After this module, you will be able to differentiate between acute and chronic pain, describe the physiologic and psychologic effects of pain, understand the concept of multimodal pain management, understand the relative potency of opioids and the various routes of administration, and understand the role of neuromodulation in the treatment of chronic pain. The transition from acute to chronic pain occurs in discrete pathophysiological steps involving multiple signaling pathways. Stimuli initiating a nociceptive response vary, but receptors and endogenous defense mechanisms in the periphery interact in a similar manner regardless of the insult. The duration and intensity of the initial stimulus leads to both peripheral and central sensitization that synergistically exacerbate pain perception. Neuroplasticity, or the physical remodeling of neuronal cytoarchitecture, occurs shortly after the onset of persistent acute pain and leads to the transition from acute pain into a chronic pain state. As a result of a peripheral lesion that persistently generates pain impulses to the spinal cord, inhibitory interneurons responsible for modulating painful nerve transmission impulses eventually die. Furthermore, glial cells remodel neuronal synapses to intensify nociceptive transmission. These pain-transmitting neurons become more sensitive, react more intensely to stimuli, and grow more connections to second-order neurons within the CNS. In short, this process of neuroplasticity leads to central sensitization in which activity-dependent phenotypic changes are seen in the dorsal horn neurons and other CNS structures, including higher centers. Acute pain typically occurs in response to an injury or illness. It usually responds well to pharmacologic interventions and is often accompanied by sympathetic nervous system arousal. Acute pain typically resolves as healing occurs. It is considered an adaptive pain response, which is supposed to be protective. It is meant to produce a behavior that promotes healing. Acute pain is typically short-lived, lasting days to weeks. There are multiple underlying mechanisms that lead to chronic pain. Neuroplasticity, or the physical remodeling of neuronal cytoarchitecture, cause changes in both peripheral and central nervous system processing. Chronic pain typically requires multimodal and interdisciplinary treatment approaches. Chronic pain typically persists beyond the normal time expected for healing to occur. The physiologic effects of pain can be seen throughout the body, starting with the brain, with anxiety and fear, depression, poor concentration, the cardiovascular and respiratory systems, where you see increased heart rate, blood pressure, increased need for oxygen, increased respiratory rate. The endocrine system is also impacted with increased blood glucose production and increased cortisol production. The gastrointestinal tract typically responds with reduced gastric emptying and reduced intestinal motility. The immune system experiences increased susceptibility to infection and increased or decreased sensitivity to pain. The muscles can become tense due to injury. There are also changes in pain processing seen in the nervous system. There are also many psychological effects of pain in the physical, psychological, social, and spiritual domains. Pain produces sleep disturbances, chronic fatigue, changes in mood, crying, anger, anxiety, irritability, irrational thinking, or behavior. People with pain can experience work-related challenges, relationship challenges, intimacy challenges, and often are socially isolated. Ultimately, they reach a state of hopelessness and experience guilt and self-pity. Because pain is a multidimensional experience, it typically requires a multimodal therapeutic approach to target the complex mechanisms leading to the transition from acute to chronic pain. The multimodal treatment of pain is based on the biopsychosocial approach. A variety of modalities are utilized to improve pain management in people with chronic pain, including sleep hygiene, lifestyle management, stress management, a variety of complementary therapies. Descending pathways can be activated to achieve pain relief through electrical stimulation, pharmacological intervention, and psychological interventions. It is through this holistic approach that people who suffer from chronic pain will experience a return to function and improvement in their overall well-being. Multimodal analgesia is a strategy by which we utilize a variety of pharmacologic and non-pharmacologic strategies to target the different areas of pain transmission. As you can see, different pharmacologic and non-pharmacologic therapies act at the different sites of action. Multimodal analgesia is directed towards 4 goals: improvement in the patient experience through better pain control, reduction in postoperative morbidity and mortality, reduction in healthcare costs, and decreased physician contribution to the global opioid epidemic. Opioids remain the mainstay of perioperative pain management despite well-recognized adverse effects including nausea, vomiting, pruritus, sedation, constipation, respiratory depression, and opioid-induced hyperalgesia. They still play a critical role, especially for procedures where a primary regional or neuraxial technique is not possible. As you can see, opioids act at all 4 sites of pain nociceptive processes and provide analgesia by mimicking the effect of endogenous opioids at specific receptors in the central nervous system. While an opioid-sparing multimodal approach to pain management is important, it's not always possible, and poor pain control impedes postoperative rehabilitation, reduces patients' health-related quality of life, causes significant personal burden, and adds to national healthcare expenditure. Moreover, inadequate analgesia in the acute postoperative period may not only lead to development of chronic pain, but also can lead to significant postoperative cognitive dysfunction. However, with the rates of new opioid persistent use that have been documented over and over again in the surgical literature, with rates between 2% and 15%, depending on the operation and patient risk factors, we have been reminded of the importance of opioid stewardship and responsible opioid prescribing. As you can see from this figure from the National Institute on Drug Abuse, in 2019, nearly 50,000 people in the United States died from opioid-involved overdoses. The misuse of and addiction to opioids, including prescription pain relievers, heroin, and synthetic opioids such as fentanyl, is a serious national public health crisis. The Center for Disease Control and Prevention estimates the total economic burden of prescription opioid misuse alone in the United States is $78.5 billion a year, including the cost of healthcare, lost productivity, addiction treatment, and criminal justice involvement. In order to better guide chronic opioid therapy in the treatment of chronic pain, the CDC released guidelines in 2016 to guide non-pain management physicians in responsible prescribing of chronic opioids. They suggested that when considering long-term opioid therapy, physicians and patients together set realistic goals for pain and function based on diagnosis. Patients are always encouraged to optimize and try non-opioid therapies. The benefits and risks of opioids are discussed with the patient, including the risk of overdose and addiction. Evaluation of risk of harm or misuse is also important. There's a variety of ways that we assess risk of harm for patients. The Prescription Drug Monitoring Program gives us information about prescriptions that the patients have obtained. Urine drug screens can be helpful for monitoring, and screening for psychological risk factors is also appropriate. Setting criteria for stopping or continuing opioids can be important, and assessing baseline pain and function at every visit. Prescribing short-acting opioids using the lowest effective dose is recommended by the CDC. Once greater than 50 morphine milligram equivalents are being prescribed, physicians are encouraged to carefully reassess the evidence of individual benefits and risks. They also recommend to avoid greater than 90 morphine milligram equivalents per day, or if using morphine milligram equivalents of greater than 90, one must carefully justify and document their decision. The opioid relative analgesic potencies are always compared to oral morphine equivalents. This is a chart of the most common opioids utilized in the treatment of pain and their relative analgesic potencies and doses when used intravenously, subcutaneously, MPO. These conversions can be useful when calculating morphine milligram equivalents and also when rotating opioid therapy. Patient-controlled analgesia is a popular modality utilized in the inpatient setting to administer opioid analgesia to patients with moderate to severe pain. It takes advantage of technology to provide opioid in a controlled and precise manner to patients with moderate to severe pain. It consists of a computerized pump with a syringe, cartridge, or infusion bag that contains opioid locked inside the pump. The program parameters include a demand dose, which allows the patient to self-administer opioid to control pain, a lockout interval, which prevents excessive drug administration, and a continuous infusion, which is not commonly used, particularly in opioid-naive patients, as it nullifies the inbuilt safety mechanism of patient control and may increase the risk of adverse events. Opioids can also be given intrathecally through. Advances in ultrasound technology have also enhanced the perioperative pain management care. They allow for more precise delivery of local anesthetic, improved success and safety of peripheral nerve blocks, and decreased reliance on opioids for perioperative pain control. Ultrasound imaging has been around for decades, often used to help diagnose infections and pain within the body. Medical advances in the past years have now extended its use all the way to the operating room, where anesthesiologists are now using it to make surgery safer. Neuromodulation is a technology that acts directly upon nerves. It is the alteration or modulation of nerve activity by delivering electrical or pharmaceutical agents directly to a targeted area. Neuromodulation devices can affect every area of the body and treat nearly every disease or symptom, from headaches to tremors to spinal cord damage to urinary incontinence. The modern era of neuromodulation began in the early 1960s with the use of deep brain stimulation to resolve chronic and intractable pain, and evolved to include spinal cord stimulation by the end of the decade. Dr. Norman Shealy, a neurosurgeon, was credited with the first implantable neuromodulatory device for the relief of intractable pain in 1967. His spinal cord stimulators were intended exclusively for pain relief. Over the last 2 decades, much work has been done to develop multiple electrode contacts and improve the understanding of placement and design of electrical field stimulation onto spinal and brain targets in order to better enhance therapeutic benefits. With such a broad therapeutic scope and significant ongoing improvements in biotechnology, it's not surprising that neuromodulation is poised as a major growth industry for the next decade. Transcutaneous electrical nerve stimulation is an over-the-counter application of neuromodulation for control of neuropathic pain poorly responsive to opioids. The nerves of the innocuous sensory system are stimulated, and they in turn inhibit transmission of nociceptive stimuli in the spinal cord. This is based on Walla-Melzak's gate control theory of pain, which states that non-painful input closes the gates to painful input, which results in prevention of the pain sensation from traveling to the CNS. As mentioned a couple of slides ago, spinal cord stimulation is an application of neuromodulation that has been in therapeutic use for over 50 years. A spinal cord stimulator is an implanted device that sends low levels of electricity directly into the spinal cord to relieve pain. Spinal cord stimulators consist of thin wires, the electrodes, and a small pacemaker-like battery pack, the generator. The electrodes are placed between the spinal cord and the vertebra in the epidural space, and the generator is placed under the skin, usually near the buttocks or abdomen. Spinal cord stimulators allow patients to send the electrical impulses using a remote control when they feel pain. Both the remote control and its antenna are outside the body. The exact mechanisms of pain relief by spinal cord stimulators still remains unknown. The basic scientific background was based initially on Melzak and Wall's gate control theory of pain. However, it seems that other mechanisms may play a more significant role in the mechanisms of action of spinal cord stimulation. Spinal cord stimulation has been established as an effective treatment in a number of painful syndromes, including failed back surgery syndrome, complex regional pain syndrome, refractory angina pectoris, and peripheral ischemic limb pain. High-quality randomized comparative clinical studies have demonstrated unequivocal clinical and cost-effectiveness in the treatment of patients with refractory neuropathic pain. Spinal cord stimulation can provide long-term pain relief with a concomitant improvement in the quality of life, daily function, and patient satisfaction, although the initial costs may be high. In summary, the transition from acute to chronic pain occurs in discrete pathophysiological steps involving multiple signaling pathways. A multimodal therapeutic approach is best suited to target the complex mechanisms leading to the transition from acute to chronic pain. A greater focus on research related to pain perception and the nervous system has led to the continued development of novel therapies for pain and greater utilization of the multimodal pain management approach. This concludes the section on ascending and descending control of pain. Thank you, and feel free to contact me anytime.